Thank you in advance for listening to and watching my presentation. It is a topic I have dealt with in clinical life across certainly every well-known chronic disease and quite a few lesser ones as well. So the title of my presentation is Self-Management for People with COPD and Pulmonary Rehabilitation. And the subtitle here, I added what you want to know and what you need to know. I added the subtitle because you might want to know more about COPD because it is more likely than not that you know somebody right now who has COPD and they might not even know it, as they may not have been evaluated for it yet. They might not even have significant symptoms at this point. So there really is a need to know, as you will see, because of the prevalence, circumstances, and consequences of disease can be quite severe. So you might have or will end up teaching exercise to someone with COPD at some point. Hopefully this presentation provides some insight. So what is COPD? There's a standard definition for it. I'll read it off here. COPD is a preventable and treatable disease with some significant extrapulmonary effects that may contribute to the severity in individual patients. Its pulmonary component is characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lung to noxious particles or gases. And really what you want to highlight out of all of this is the extrapulmonary effects of COPD. So in terms of the prevalence or how frequently encountered in the general population you might encounter COPD. We've gotten a considerable amount of data on that over the past 20 to 25 years, not only in the US but internationally. And it's an alarmingly high prevalence, again, to the point where assuredly you will interact with someone who has COPD weekly and maybe even daily. So in the general population, although estimates will vary to some degree, it's about 6.3%. And going back to 2013, that would be approximately 15 million people. So quite a few people do have the disease. And you can see by age that as you age, the likelihood of COPD, encountering COPD in the general population goes up. And then as people continue to age, you start to see it drop. And of course, that's because of the unfortunate early mortality associated with the disease. And interestingly, COPD for the longest time was always thought of as a predominantly male disease, as occupational exposure, starting with the Industrial Revolution actually, was the primary risk factor, not smoking. But it turns out that women have now outpaced men in terms of having this disease. So what are the risk factors for COPD? Although smoking is the most well-known risk factor, it is not the only reason one can end up with COPD. You can see genetic and epigenetic factors contributing to it. Certainly direct first-hand or second-hand smoking exposure is a risk factor. But prenatally even, exposure of the fetus to smoking, either first-hand, maternal smoking, or second-hand via the mother, as well as the mother having asthma, and malnutrition of the mother can be factors in developing it. Perinatally, you can see premature delivery, low birth weight, and malnutrition at that time to be predictive of having early COPD, that is, having COPD at an unusually young age. And even during childhood and adolescence, malnutrition, bronchopulmonary dysplasia, infectious disease, airway hyperresponsiveness, sometimes we think of as asthma, can also be factors. And even later on in adulthood, through the normal aging process and possible exposure, you can see people develop the disease later in life. So in terms of mortality, even though life expectancy has generally gone up worldwide over about the past 30 plus years, COPD is still increasing in mortality rate and is now the third leading cause of death worldwide, with an estimated 3.23 million deaths having occurred in 2019. Another thing we can think about is the disability associated with it. So there's a couple of points here to make that we see an increase in the disability metrics as far as COPD occurring. So not only is it more common, not only people dying of it more frequently, we're also seeing that people are experiencing disability at higher rates too. And that plays out in terms of an inability, of course, to work and to engage in a lot of the activities we usually do. And we have an idea, again, of why this is happening, and many of these things are preventable, which, for example, smoking. Certain occupations have exposure where we should have clearly been dealing with that a long time ago. Environmental factors are big. And also, too, just being physically inactive and having a high body mass index can all be risk factors for a more disabling form of COPD. And now, I think it's important to point out COPD is extraordinarily expensive. It's a huge burden on the healthcare system, not only in the U.S. but elsewhere. And here's a little bit of a rundown of some of the costs that are associated with it. You see an annual total cost, even in 2015 dollars, of over $30,000 per patient. And when you factor out how many patients actually have COPD in the U.S., that's a very large number. That and the medical management is extraordinarily high. And that goes for regular outpatient visits with a physician or a pulmonologist, emergency room visits, hospitalization, and readmission to hospitals. Each of these are seminal events that you really try to avoid because they usually predict really poor outcomes and early mortality. So one of the things that we get concerned about is what's called acute exacerbation of COPD, which is effectively a worsening of disease that can disrupt the natural history of the disease, leading to its progression. And the effects that come out of acute exacerbation are obviously people being less physically active, the lack of tolerance for exercise and physical activity goes way down, the quality of life goes down, we start seeing more disability, we start seeing other diseases, comorbid diseases emerging, we see early mortality rates going up. And of course, as that process plays out, the medical burden is much higher and the economic burden is much higher. And yet, it is possible to try to reduce the likelihood of these types of events happening. So, there was a major shift that happened probably starting about 20 years ago, where we started seeing COPD not only as a disease that exists within the lungs, but also exists beyond the lungs. So we now think of COPD as a more heterogeneous or variable type of disease with systemic inflammatory components, and often the interaction effects between COPD and other types of chronic diseases are quite powerful, and the genetic factors also play a big role. And although there's some debate on this, we see that although the lungs are the initial site of tissue damage, that the inflammatory processes in the lungs often will spill over into the systemic circulation, and that may be the reason why we see extrapulmonary effects such as skeletal muscle dysfunction. So, exercise intolerance is one of the cardinal signs of COPD, and it's usually symptom-driven, usually shortness of breath, and ultimately it leads to a poor quality of life. And one of the things we really look for is breaking what we call a downward spiral. This is a situation where somebody with COPD with very severe symptoms, shortness of breath or dyspnea as we call it clinically, inactive, very difficult time even getting up and walking across the house, and you start seeing that their aerobic capacity also declines. And in many cases, as people with COPD try to exert themselves, they are incapable of getting anywhere near their physiological limits. Usually the symptoms are so powerful, the shortness of breath is so powerful that that's what's going to shut them down long before they get anywhere near what their actual abilities are. And so in the clinic, we have to not only look objectively at what someone's exercise capacity is, aerobic capacity is, but we also have to ask them how they feel and get a subjective rating as well, because usually the subjective rating is going to be a better indicator of what their exercise capacity actually is. So another concern that we have for COPD when a patient comes in for evaluation is you see somebody, a very frail person, clear muscle wasting, their BMI is often very strikingly low, and you worry about the development of cachexia. Cachexia is a complex metabolic syndrome associated with underlying chronic disease. In this case, we're talking about COPD, and involves an involuntary progressive loss of skeletal muscle mass with a variable loss of fat mass. We've tried to standardize the definition of cachexia using BMI, and there's a couple of different cutoff scores for that. But some people have criticized the use of BMI as it may be misleading because sometimes we do see muscle wasting, not only in people with normal body weight, but people even that are overweight or obese on the BMI scale. Typically, though, the cachectic patient is going to have a low BMI and also have low fat-free mass. So now we're getting into an area of particular interest for me, which is skeletal muscle dysfunction. And I would say it's really at the heart of what I do daily in the clinic. And it's a very difficult task on many levels, but it's certainly a worthy one. It's a major consequence of cachexia. Now, we see a lot of terms thrown around to describe the state of muscle, skeletal muscle. Cachexia, muscle atrophy or wasting, primary, secondary, confirmed, or severe sarcopenia. It gets a little bit confusing as we get into the sea of terminology, but we have some standardized definitions. Muscle atrophy or wasting is really a decrease in individual muscle fibers independent of fiber type, indicating a shift in protein balance towards protein catabolism. Primary sarcopenia is really a muscle atrophy that's associated with aging, the natural aging process, assuming somebody's not doing something about it, like resistance training. Secondary sarcopenia is a special form of sarcopenia where factors beyond aging, such as chronic disease, are the reason why somebody's experiencing that. And then we can think of sort of levels of sarcopenia, probable sarcopenia, which is really an early warning sign that somebody has low muscle strength, which can have functional consequences. Confirmed sarcopenia is usually where we can now measure that low muscle mass. And severe sarcopenia is a situation where now that loss of muscle mass is very clearly obvious in daily life in terms of activities of daily living. So we can highlight a couple of interesting cellular changes that are associated with skeletal muscle disease. And really, there's an unusual paradox we see in COPD. So when you look at, first, there being a shift in the muscle fiber type complement within skeletal muscle. In this case, you see a loss in the limb muscles, at least. You see a loss of oxidative capacity in skeletal muscle and overall muscle atrophy. So not only is the fiber type complement changing, and with it the endurance of the muscle, there's an overall loss of all fiber types, leading to further loss of muscular endurance as well as muscular strength and power. So it's a double effect. And there's some other changes that happen cellularly or around muscle fibers, such as loss of muscle capillaries and myoglobin content, reduced level of oxidative enzymes, and reduced muscle perfusion and oxygen uptake, as well as deranged muscle cell metabolism and acid balance base. So we have some insight into why this occurs. It is true that disuse atrophy is the primary factor in the pathogenesis of skeletal muscle disease, But we do see other factors such as inflammation being a factor as well. And some of the same preventable things that go with it, some less preventable than others, but quitting smoking obviously would be a good thing to do. In some cases, patients end up on oral corticosteroids, sometimes for too long a period of time, which can be very problematic, inducing a form of myopathy. And we see other factors like oxidative stress, hypoxia, hypercapnia, and comorbidity being a factor, malnutrition being a factor, and certainly something that we definitely can do something about, which is what levels of physical activity somebody's getting. So we can make a comparison between the general public as well as with people with COPD, and an interesting contrast there between people with COPD who are in the general population with a noticeable 8% prevalence of sarcopenia, but those in assisted living facilities where, in many cases, very limited tolerance for physical activity, as high as 63% prevalence. And we also know that as the disease worsens, we usually see that it's the case that skeletal muscle dysfunction becomes more powerful. So, again, going back to the risk of worsening of disease, anytime somebody experiences that, there's a concern for cachexia. And that, of course, again, as the disease severity gets worse and worse, we see people become weaker and tend to be wasting away. And this probably plays into an acceleration at that point of COPD progression, which is very, very bad. So people getting below a BMI of 20 at that point have an estimated 25% 5-year survival rate. So what do we do about it? What's the remedy for this? And that's pulmonary rehab, which has, again, a standardized definition, a comprehensive intervention based on a thorough patient assessment, which is very important, followed by patient-tailored therapies, also important that we individualize care, but are not limited to exercise training, education, and behavior change. Behavior change, one example, might be self-management, which is designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence to health-enhancing behaviors, which, again, that plays into the self-management concept. It's a multidisciplinary effort, and by trade, I'm a physical therapist. I've worked in every type of patient population, from sports medicine to orthopedics to neuro to specializing in chronic diseases, especially respiratory diseases. But you'll often see other professionals that work there. In my clinic, it is exclusively physical therapy based, and that's actually somewhat common across the country. So to get a little bit into the evidentiary basis for pulmonary rehab, which is very well established, there was a important meta-analysis done by McCarthy in 2015, included 65 randomized controlled trials, nearly 4,000 participants, and really looking at the benefits of pulmonary rehab programs for people with COPD in terms of reducing symptoms, getting patients to self-manage, and certainly improving exercise capacity and ultimately quality of life. And it was such a conclusive meta-analysis that the author wrote, "It is our opinion that additional randomized controlled trials comparing pulmonary rehab and conventional care in COPD are no longer warranted." Usual care was usually a control group, and usually this was without any education, any type of intervention. Really, you're on your own kind of thing, with the exception maybe of drug therapy. But certainly pulmonary rehab is strongly recommended for all COPD patients. So, pulmonary rehab is a comprehensive intervention. It's going to cover a lot of areas. Exercise is, it's a famous quote for us, a cornerstone of all pulmonary rehab programs. Assessment is very important, and really one of the reasons why we assessment is because we don't believe in generic care. you really are trying to tailor somebody's rehabilitation to what their current abilities are and a long list of factors. And so we're going to look at functional performance, and certainly we do get into respiratory muscle function. And we also look at balance. It's a standardized question, as well as fall history and how people are performing their activities of daily life. And absolutely testing musculoskeletal limitations. And we think it's just very important that you engage in testing before exercise training, which unfortunately does not always happen in some programs. But there's going to be aerobic exercise, and we do indeed do interval training with these patients. In fact, it can be quite effective. Resistance training and even flexibility training or stretching. So again, the 6-minute walk test is very easy to do. Patients are supposed to try to do their best, but you also have to ensure their safety when doing any type of stressful testing. You're looking at both subjective and objective variables when you're doing the testing. It has excellent reliability, but people often will do better if they do repeat testing, simply because they now know how the test feels and have a better understanding of it. And if you continue to do the test, eventually, as expected, you'll see a fatigue effect. Some patients really can't even complete a single 6-minute walk test or have to rest multiple times during the test. But it is a valid measure of exercise capacity and informative. And we have an idea also of what we call a minimally clinically important difference when comparing, say, a baseline 6-minute walk test with a follow-up. We have an idea of what is relevant to the patient, probably in daily life. And again, the test tends to correlate with a lot of important outcomes, such as the risk of hospitalization and early mortality. It also is an indicator of whether or not what we're doing in pulmonary rehab is working. And I would say that it's very, very rare that you're going to see adverse events if you're following standardized testing protocols. And some patients are very much going to desaturate to often severe levels, which is not a place you really want someone to be. We do provide oxygen supplementation for most patients who do the test, because they will desaturate to dangerous levels. And you'll see that in many cases, patients just find the symptoms associated with the testing too powerful, and ultimately will stop the test long before they would ever become particularly hypoxic. So let's talk about self-management. It is a topic I've become very interested in over the past few years. It seems pretty simple on the surface, but in practice it is remarkably challenging, and it's something that I deal with every day, all day, to varying degrees. It can be defined as an individual's ability to manage their symptoms, treatment, and physical and psychosocial consequences and lifestyle changes inherent to life with a chronic condition. We have the concept of self-management, but if we extend that to collaborative self-management, what we're really saying is that we're trying to develop patient self-efficacy, which requires them to learn more about the disease and learn about its effect on them and develop the skills necessary to manage it. But they are coordinating that with a clinical team who can provide an objective perspective on things. So it is a defined process. There's goal setting, which is something, again, we do with each patient and update them. Problem solving, decision making, and really an evolving action plan that's primarily driven by the patient. So any goals that we set are really patient-centered goals. Positive adaptive behaviors are crucial to avoiding exacerbations. And one of those things is avoiding the triggers that are associated with them. And when they don't engage in medical management appropriately, that can often be a problem. And when they don't engage in exercise and physical activity, that can also be a problem. And so collaborative self-management is something that we would try to do in pulmonary rehab. That's usually the setting where it occurs. But as with any concept, there is criticism, and self-management has been thought of as a possible double-edged sword where patients end up being set up to fail. What we mean by that is in the course of the process, patients may start to have a good period of time for themselves as far as the disease is concerned, and things are going well, but that may not last. And when the self-management really comes into play is when things do turn bad. And so we can be in an inadvertent installation of overconfidence in this patient where they may avoid or just dismiss the legitimately necessary medical care that they need. We find that studies of self-management have been mixed, and I think we're still trying to understand why that's the case. There was one particular study on self-management where it turned out that higher mortality rates were observed in the self-management of disease group as opposed to the usual care group, and the study had to be stopped immediately. And we ultimately see a pretty low rate. I think 40% is what's in the literature. That's probably an overestimate based on my experience. So if we move into some of the literature, I looked at 4 studies, each involving meta-analysis of multiple randomized controlled trials. The benefit of meta-analysis is you get all the evidence in one place, and when there's sufficient similarity in the studies, you have a much more powerful study than an isolated randomized controlled trial, and the estimate of the effect of the interventions is considerably more precise, and you have more power to find differences. But you usually will get a range of intervention parameters from study to study, which can be informative. If there is a lot of heterogeneity or differences amongst studies on the topic, it simply highlights the lack of discourse on the topic or just downright disagreement amongst people who are involved in that kind of work and on how one should intervene with patients. The downside is sometimes that meta-analysis usually reveals that the quality of research is low and the risk of bias is high. So I'm not 100% sure how to pronounce the first author's name. It looks like Jean-Joie, but it might be a silent J, I'm not sure. But they were looking at the problem that efficient, cost-effective healthcare really requires patient self-managing COPD, that it's inevitable. And one way to accomplish this is to use digital interventions, which could be an effective means of behavioral change techniques and motivate patients to improve their own outcomes. So this is a Cochrane systematic review, which has standardized criteria for how they're conducted. And the digital self-management tools were done either with or without collaboration versus a usual care group or control group, and a multi-component intervention, including self-management, that was ultimately compared against either standard, usual, or control group. The randomized control trials included in this meta-analysis ranged all the way from 13 weeks to a full year. And the ultimate sample size they had across all studies was a little over 1,500 people, and they included disease levels of all severity. It's a common problem in studies where there is bias due to a lack of blinding, and that is because many of the interventions in exercise, you really can't effectively blind the participants. And sometimes the assessors are the same people that are caring for the patients, so it's difficult to blind them as well. And they used a couple of different means here, mobile phone in 3 studies, through phone or text communication, smartphone apps, or internet. And again, they point out in this study there was imprecise measurement and a lack of blinding, which again, that's sometimes unavoidable, which influenced the study. And they broke down differences in a 6-minute walk test or a measure of aerobic capacity. looking at how long people were using the digital intervention with or without support, and at any time point, we didn't see any differences between groups. Okay. And when you look at the 95% confidence intervals, which effectively what we're saying is that if we repeated the study, 20 times, only once would we expect the true population value to be outside of that range, is what effectively that means. But you can see these are very wide, very broad estimates of here, and that usually says that there are certain variables that are influencing the results that probably aren't considered or controlled for in the study. And when we look at the multi-component intervention, which only included one study, we also see a non-significant difference with a very wide confidence interval. And so the conclusions of the authors where there's insufficient evidence of benefit or harm for either digital self-management intervention for aerobic capacity based on the 6-minute walk test. Now, an important point that I always make is a famous quote from the late cosmologist and astronomer Carl Sagan, kind of an axiom in science: absence of evidence is not evidence of absence. Sometimes you engage in this process and you end up not really coming to a very useful conclusion. That doesn't mean that it ultimately there isn't some truth to it. It's just at this point, either through poor study quality or not really figuring out how to ultimately reduce it to a testable model, you can't at this point draw a fair conclusion. And one of the limitations they point out, which is very common, that there's often not standardization of interventions. You can see a little bit of variation or a lot, and that can certainly have a big effect on the results.